In healthcare data management, data types are classified into structured, unstructured, and semi-structured categories. Provide an example for each category and explain the challenges and advantages of working with each data type in a healthcare setting. How do data governance frameworks address these challenges? Answer: structured data refers to data that is highly organized and stored in a tabular format, such as relational databases. An example in healthcare is patient demographics stored in an electronic health record system. Challenges: structured data is easy to analyze and query, but often lacks the depth of unstructured data. The challenge is limited flexibility in representing complex clinical information. Advantages: it's easy to store, search, and analyze using SQL queries. Unstructured data includes data that does not follow a specific format, such as clinical notes or images, e.g. X-rays, MRIs. Challenges: unstructured data is difficult to analyze and requires specialized tools like natural language processing (NLP) to extract useful information. Advantages: it provides rich contextual insights into patient health, such as in-text comments from healthcare providers. Semi-structured data falls between structured and unstructured data and includes formats like XML or JSON, which contain some organizational structure but not in a fixed table format. Examples in healthcare include clinical trial data stored in XML format. Challenges: parsing semi-structured data can be complex and tools for analysis may not be as widespread as those for structured data. Advantages: provides more flexibility than structured data, allowing diverse data to be integrated. Data governance frameworks like HIPAA in the US ensure data privacy and quality across these data types by defining roles, responsibilities, and policies for managing and securing health data. Such frameworks help ensure that data is accurate, complete, and timely even when it comes from diverse sources like HR systems, administrative claims, or clinical trials. What are the key differences between centralized, federated, and hybrid models of health information exchange? Hi. Discuss the advantages and disadvantages of each model, particularly in terms of data privacy, accessibility, and interoperability in a multi-facility healthcare environment. Answer: centralized high. In this model, all health data is stored in a central repository that can be accessed by multiple healthcare providers. Advantages: simplifies data access for providers since all data is available in one location. It improves the ability to share patient information across different healthcare systems. Disadvantages: raises significant data privacy concerns as a single breach in the central repository can compromise all patient data. Additionally, it requires substantial infrastructure to maintain the repository. Federated high. In this model, each healthcare provider keeps its own data, and only certain data elements, such as patient summaries, are shared across the network when needed. Advantages: protects data privacy since individual institutions control their data. It allows more localized control over sensitive information. Disadvantages: it can be more difficult to access data across institutions, leading to interoperability issues and delays in information retrieval. Hybrid high. This model combines both centralized and federated approaches where some data is stored centrally and other data remains local at the institution level. For example, patient identification and certain types of clinical data may be centralized, while detailed medical records remain with each provider. Advantages: balances the need for data accessibility with data privacy and security concerns. It also facilitates better interoperability between systems. Disadvantages: more complex to manage and requires careful governance and coordination across multiple healthcare providers. In multi-facility environments, hybrid HIE models are often preferred as they provide a balance between security and data accessibility while addressing the interoperability challenges of multiple disparate healthcare systems. Sarah, the Chief Data Officer at a large healthcare network, is leading a project to integrate patient data from multiple hospitals within the network. The hospitals use different electronic health record systems, and patient identifiers are not consistent across the systems. Sarah has decided to implement a Master Patient Index (MPI) to resolve these issues. What steps should Sarah take to ensure that the MPI works effectively for data integration across the network? What are the key challenges she might face, and how can they be mitigated? Answer: steps to implement an effective MPI. Standardize patient identifiers. The MPI should standardize patient identifiers by creating unique identifiers for each patient that will be consistent across all systems. Data mapping and ETL processes. Sarah should map the data from different HR systems to the centralized MPI. The extract transform load (ETL) process will need to address data anomalies such as duplicate or incomplete records. Data quality management. Implement quality assurance processes to ensure data accuracy, consistency, and completeness across all systems involved. Data stewardship. Assign accountability for data stewardship to ensure continuous monitoring and maintenance of the MPI. Challenges: data mismatches and duplication. Since patient identifiers are inconsistent across systems, there may be errors in matching patients accurately. This could lead to the creation of duplicate records in the MPI. System interoperability. Different HR systems may use different standards for patient data, which can complicate integration. Data privacy concerns. Sharing sensitive patient information across systems may raise privacy and security issues, especially under regulations like HIPAA. Mitigation strategies. Use advanced algorithms for record matching, such as probabilistic matching, to reduce the risk of duplication. Develop a clear data governance framework to ensure that all systems follow standardized data protocols. Implement robust encryption and access control policies to protect sensitive health data and ensure compliance with privacy regulations like HIPAA. Explain how clinical decision support systems (COSS) can improve patient outcomes in a healthcare setting. What are the main types of CDSS and how do they integrate with existing health IT systems? Additionally, discuss the ethical considerations and potential risks associated with the use of CDSS. Answer: CDSS overview. Clinical decision support systems are designed to assist healthcare providers in making clinical decisions by analyzing patient data and providing evidence-based recommendations. These systems can help reduce medical errors, improve diagnosis accuracy, and streamline treatment plans. Main types of CSS. Knowledge-based CSS. These systems rely on a knowledge base of clinical guidelines and algorithms to provide decision support. They use rule-based logic to suggest treatment options. Non-knowledge-based CSS. These systems rely on data-driven approaches such as machine learning and predictive analytics to identify patterns and provide decision support based on historical patient data. Integration with existing health IT systems. CDSS integrates with electronic health records systems, laboratory information systems, lists, and other health IT platforms to retrieve patient data in real time and provide actionable insights. This integration ensures that the decision-making process is informed by the most up-to-date patient information. Ethical considerations and risks. Bias in decision-making. CDSS may inherit biases present in the data used to train the system, potentially leading to suboptimal treatment recommendations for certain patient groups. Over-reliance on technology. Healthcare providers may become over-reliant on CDSS recommendations, leading to reduced clinical judgment and misdiagnosis. Data privacy. CDSS often requires access to sensitive patient data, which raises privacy concerns under regulations like HIPAA. Ensuring data security is critical to prevent unauthorized access. Ethical use of CDSS requires healthcare providers to ensure that these systems are used as a tool to support decision-making rather than replacing human judgment. What are the most common types of data anomalies found in healthcare datasets? How can these anomalies impact clinical decision-making and patient care? Provide specific examples of how to detect and resolve these anomalies in a real-world healthcare setting. Answer: common types of data anomalies. Missing data. Healthcare datasets often contain missing values, which can result from incomplete patient records or errors in data entry. Duplicate records. When patient information is entered multiple times, either due to clerical errors or system malfunctions, it creates redundancy. Outliers. Extreme values in clinical data, such as unusually high or low test results, can be indicative of errors or rare conditions. Inconsistent data. Discrepancies between different datasets, e.g., different HR systems, or conflicting information about a patient's history can lead to inconsistent records. Impact on clinical decision-making. Missing data. If critical patient information is missing, e.g., allergy history, it could lead to medication errors or inadequate care. Duplicate records. This can confuse healthcare providers, leading to incorrect treatments, unnecessary tests, or delays in patient care. Outliers. These can skew statistical analyses and potentially lead to misdiagnosis if the outlier is incorrectly interpreted as a normal condition. Inconsistent data. Inconsistent patient information can lead to errors in clinical decision-making, such as administering the wrong treatment or missing crucial health indicators. Detection and resolution. Automated validation. Use of automated tools and algorithms to check for missing or duplicate data. Data cleaning, regularly cleaning data by identifying and correcting inaccuracies through manual or automated processes. Cross-system reconciliation, implementing data governance processes that ensure consistent, accurate data across all systems. Explain the role of healthcare data warehousing in supporting large-scale healthcare analytics. What are the key components of a healthcare data warehouse, and how does OLAP, online analytical processing, support decision-making in a clinical setting? Answer. Role of healthcare data warehousing. Healthcare data warehousing involves collecting, storing, and managing large volumes of structured and unstructured data from various healthcare sources, such as HR systems, laboratory data, and administrative records. This data is then organized in a way that supports advanced analytics, reporting, and decision-making. Key components of a healthcare data warehouse. Data staging area. Raw data from different sources is initially stored and processed before it is loaded into the warehouse. Data integration layer. This layer is responsible for integrating data from multiple sources, ensuring consistency and accuracy across all data. Data marts. Specialized subsections of the data warehouse that are tailored for specific purposes, such as clinical, financial, or operational analytics. OLAP cubes. These are multidimensional databases used to perform complex queries on large datasets, allowing for quick retrieval of summary and detailed data. OLAP in healthcare. OLAP supports healthcare analytics by enabling the creation of multidimensional cubes, which allow healthcare analysts to query and analyze data along multiple dimensions, e.g., patient demographics, disease types, treatments, and outcomes. This enables faster and more efficient decision-making in clinical settings, such as identifying trends in patient care, monitoring treatment outcomes, and improving resource allocation. Describe the extract transform load (ETL) process used in healthcare data integration. What challenges may arise during each step, and how can these be addressed to ensure successful data integration? Answer. ETL process. Extract. Data is extracted from various healthcare sources, e.g., and its administrative databases, patient registries. Challenges. Different data formats, structured, semi-structured, unstructured, may make extraction difficult. Solution. Standardize extraction procedures to accommodate diverse formats and integrate data more easily. Transform. The extracted data is cleaned, normalized, and transformed into a standard format suitable for analysis. Challenges. Inconsistencies and missing data in the raw data may complicate transformation. Solution. Implement data cleaning algorithms and manual validation to ensure data integrity. Load. Transformed data is loaded into a centralized repository or data warehouse for further analysis. Challenges. Load failures due to incompatible data, structures, or errors in the transformation process. Solution. Perform rigorous testing and validation to ensure the data loading process is seamless and accurate. ETL is critical to healthcare data integration as it ensures accurate, clean, and usable data is available for decision-making across systems. Challenges can be addressed through automated tools, data governance, and continuous monitoring. What are the key components of healthcare information systems, and how do they interact with each other? Discuss the integration of clinical and administrative systems in a healthcare network. Answer. Key components of electronic health records, EHR, the primary source of clinical patient data. Laboratory information systems, LIS, manages lab test results. Radiology information systems, RIST, handles radiology images and reports. Administrative systems manage non-clinical data such as billing, scheduling, and patient admission. Integration. Clinical and administrative systems must communicate effectively to streamline patient care and billing processes. For example, patient information from the HR should automatically update billing systems to reflect changes in treatment. You are tasked with predicting future healthcare costs using predictive analytics techniques. You are given a dataset with patient data that includes age, BMI, and a history of chronic conditions. How would you use regression models to forecast the cost, and which factors would you prioritize for your predictive model? Answer. In predictive analytics, a regression model can help forecast continuous outcomes like healthcare costs. The first step is to assess the variables in the dataset. Since you are predicting healthcare costs, variables such as age, BMI, and chronic conditions, e.g., diabetes or hypertension, are relevant predictors because they have been shown to correlate with higher healthcare expenses. Linear regression could be a good starting point where healthcare costs are the dependent variable and age, BMI, and chronic conditions are independent variables. Important factors to prioritize: Chronic conditions. These often have the largest impact on healthcare costs, including a variable for whether a patient has a chronic condition. E.g., 1 for yes, 0 for no is crucial. BMI. Body mass index (BMI) is linked with a range of health problems like cardiovascular diseases, making it a strong predictor. Age. As people age, healthcare costs typically increase, so this variable should be included as well. After running the regression analysis, you would evaluate the model's fit using metrics like R-squared and p-values to determine the strength and significance of the predictors. You are analyzing healthcare delivery in a large urban hospital system. The hospital wants to optimize patient wait times using simulation techniques. What factors would you need to include in the simulation model, and how would you interpret the results to suggest actionable improvements? Answer. In prescriptive analytics, simulation techniques allow for testing different scenarios to optimize outcomes. To simulate and optimize patient wait times, the following factors should be included in the model. Patient arrival rates. The rate at which patients arrive at the hospital, e.g., every 10 minutes, is crucial to modeling patient flow. Staff availability. Number of healthcare providers available, including doctors and nurses, as this directly affects how quickly patients can be seen. Treatment time. The average time required to treat patients, which can vary by condition. Queuing system. How patients are queued, which could be based on severity. Triage system or first come first serve. Patient prioritization. Some patients may require immediate attention, e.g. emergency cases, while others may. After running the simulation, you would analyze the results using metrics like average wait time, patient throughput, and staff utilization. A sensitivity analysis could identify which factors, e.g., increasing the number of staff or adjusting patient flow protocols, would most significantly reduce wait times. Actionable improvements could include adjusting staff shifts to ensure adequate staffing during peak times, implementing a more effective triage system to prioritize urgent cases and reduce bottlenecks, increasing patient throughput by streamlining non-critical processes like registration. A healthcare analyst is using Kaplan-Meier survival analysis to examine the survival rates of patients undergoing a new treatment for heart disease. What key assumptions should the analyst consider when applying this method, and how would the results inform clinical decision-making? Answer. The Kaplan-Meier survival analysis is used to estimate the probability of survival over time, and it provides a way to handle censored data, i.e., patients who drop out or have not yet experienced the event by the end of the study. Key assumptions to consider include independent censoring. The reason for censoring should be unrelated to the survival time. For example, a patient moving to a different hospital should not be at greater risk of dying than those who remain in the study. Time and variant hazard rate. The analysis assumes that the risk of an event occurring, e.g., death, is constant over time within the defined intervals. Homogeneity of groups. Patients in the study should be relatively similar in characteristics, particularly when comparing different treatment groups. The results, which show survival curves for different treatment groups, can help inform clinical decision-making by identifying whether the new treatment significantly improves survival rates compared to standard treatments, offering insights into when the greatest risk of mortality occurs, helping clinicians time interventions more effectively. Mr. Thompson is conducting a study on the effectiveness of a new public health intervention to reduce smoking rates in various age groups. He decides to collect data from 5 different geographic regions, but each region has a different population size. He uses a stratified random sampling technique to ensure that each region is adequately represented. How should Mr. Thompson determine the sample size from each region, and what are the advantages of using this sampling technique? Answer. Mr. Thompson should first stratify the population by region. The goal of stratified sampling is to ensure that each subgroup or stratum is adequately represented in the sample based on characteristics like the region's population size or smoking rate. To determine the sample size from each region, Mr. Thompson should use proportional allocation, which involves taking a sample from each region proportional to its size. If Region 1 has 100,000 people and Region 2 has 200,000 people, then Region 2 should contribute twice as many samples as Region 1. Advantages of stratified random sampling include improved precision by ensuring each subgroup is well represented. The estimates of smoking rates are more precise compared to simple random sampling. Enhanced comparison. It allows for comparisons between different regions, improving the understanding of how the intervention might work in each region. Increased statistical power. Stratified sampling helps reduce sampling error, leading to more reliable and valid results. A public health analyst is using heat maps to visualize the geographic distribution of a flu outbreak. What considerations should the analyst keep in mind when creating the heat map to ensure it is accurate and informative for policymakers? Answer: when creating a heat map for public health data, the analyst should consider the following: geographic boundaries. Ensure that the boundaries, e.g., districts, zip codes, accurately represent the areas under analysis and that the data is aggregated appropriately to reflect regional variations. Color scale. The choice of color scale is crucial. Using a diverging color scheme, e.g., blue to red, helps highlight differences in flu prevalence. It's important to ensure that the color scale is intuitive and avoids misleading interpretations. Data normalization. Normalize the data for population size, as a region with a larger population might naturally report more cases. Use rates, e.g., cases per 100,000 people instead of raw counts to ensure fairness across regions of different sizes. Resolution. Choose the correct level of granularity to ensure the heat map provides useful information. Too broad a level may obscure important details, while too fine a level could create unnecessary complexity. Data accuracy. Ensure that the data used to create the heat map is current and accurate. Outdated or incomplete data could result in misleading conclusions. A researcher is analyzing the monthly number of hospital visits for a specific disease over the past 2 years. The data appears to show an increasing trend over time. What are the key steps involved in conducting trend analysis for this time series data? Answer: key steps in conducting trend analysis for time series data include data visualization. Plot the data over time to visually identify the trend, seasonality, and any irregular components. Smoothing the data. Apply smoothing techniques such as moving averages or exponential smoothing to eliminate short-term fluctuations and highlight the underlying trend. Trend detection. Use methods like linear regression or polynomial trend models to model the trend over time. In simple linear regression, the dependent variable, number of visits, is regressed on time, e.g., month number, seasonality adjustment. If the data shows periodic fluctuations, e.g., higher visits in certain months, use seasonal decomposition or Fourier analysis to adjust for seasonality. Forecasting. Use the identified trend to forecast future values with techniques such as ARIMA, autoregressive integrated moving average models, or exponential smoothing. Model validation. Validate the model using out-of-sample data or cross-validation techniques to assess its accuracy and robustness. A hospital is testing a new drug to see if it reduces recovery time. The significance level is set at 0.5. What are the potential consequences of making a type I error and a type I error in this scenario? Answer: type I error, false positive. A type I error occurs when the hospital incorrectly rejects the null hypothesis and concludes that the drug reduces recovery time when, in reality, it does not. The consequence could be unnecessary adoption of the drug, leading to additional costs and potentially harming patients. Type I error, false negative. A type I error occurs when the hospital fails to reject the null hypothesis and concludes that the drug does not reduce recovery time when, in reality, it does. The consequence could be the missed opportunity to use an effective treatment, potentially prolonging patient recovery times and increasing healthcare costs. Understanding the balance between these errors is critical for the hospital in making informed decisions. A healthcare analyst has built a predictive model to forecast patient readmission rates within 30 days of discharge based on a set of demographic and clinical variables. After applying cross-validation, the model shows a high accuracy but poor performance on the test dataset. What does this suggest about the model, and what steps should be taken to improve it? Answer: this situation suggests that the model may be overfitting, meaning it has learned patterns that are specific to the training dataset but fail to generalize to unseen data, the test dataset. Overfitting occurs when the model is too complex and captures noise rather than the underlying relationships. To improve the model, the following steps can be taken. Simplify the model. Reduce the complexity by using fewer features or applying regularization techniques, such as lasso or ridge regression, to penalize overly complex models. Collect more data. Overfitting can be mitigated by having a larger and more representative dataset to help the model learn generalizable patterns. Cross-validation. Ensure proper cross-validation techniques, such as k-fold cross-validation, to assess the model's performance on different subsets of the data and detect overfitting more reliably. Use ensemble methods. Techniques like random forest or gradient boosting can help improve generalization by combining multiple weaker models into a stronger one. A biostatistician is evaluating the survival time of cancer patients after receiving a new treatment. The Kaplan-Meier survival curve is used to analyze the data. What information can be derived from A Kaplan-Meier survival curve, and why is it a valuable tool in healthcare research? Answer: the Kaplan-Meier survival curve is a non-parametric statistic used to estimate the survival probability of patients over time, particularly useful in clinical trials or studies where time to event data, e.g. survival times, time to relapse, is of interest. It provides a visual representation of the survival experience of patients in a study. Key insights that can be derived from the Kaplan-Meier curve include survival probability over time. The curve shows the probability of surviving at different time points after the start of the treatment or event, e.g. diagnosis or surgery. Median survival time, the point at which 50% of the patients have experienced the event, such as death, relapse, or other clinical outcomes, is often marked on the curve, indicating the median survival time. Comparing groups, the Kaplan-Meier curve can be used to compare the survival distributions of different patient groups, e.g. treatment versus control groups. The Kaplan-Meier estimator is crucial in healthcare research because it helps clinicians assess the effectiveness of treatments, understand patient prognosis, and make informed decisions about healthcare interventions. A healthcare provider is testing a new drug aimed at reducing blood pressure. They hypothesize that the drug reduces systolic blood pressure by 8G. After conducting a controlled trial, they perform a hypothesis test with a significance level of 0.5. What is the meaning of the p-value in this context, and how should the provider interpret the results? Answer: in hypothesis testing, the p-value represents the probability of obtaining results at least as extreme as the ones observed, assuming that the null hypothesis is true. It essentially quantifies the evidence against the null hypothesis. If the p-value is less than 0.5, the results are considered statistically significant, meaning there is strong evidence to reject the null hypothesis. This suggests that the new drug likely does reduce systolic blood pressure by a significant amount. If the p-value is greater than 0.5, the results are not statistically significant, meaning there is insufficient evidence to reject the null hypothesis. This indicates that the drug's effect on systolic blood pressure is not significantly different from the baseline. However, it is important to interpret the p-value in the context of the study design and the clinical significance of the results. A low p-value does not necessarily mean the effect is clinically meaningful, and further research may be necessary to confirm the findings and assess the practical impact of the drug. Which elements must be included in a clinical trial protocol to ensure compliance with FDA regulations, and how do these elements safeguard patient safety and data validity? Answer: a clinical trial protocol must include objective and purpose. Clearly define the hypothesis, endpoints, and significance. Study design. Randomization, control group blinding, and sample size determination ensure bias minimization and statistical validity. Patient selection criteria. Inclusion-exclusion criteria ensure appropriate cohort selection and patient safety. Safety measures. Adverse event monitoring, stopping rules, and emergency protocols minimize risks. Informed consent process. Compliance with the FDOS 21 CFR Part 50 ensures ethical participation. Data collection and analysis plan. Specify standardized methods for data capture and statistical analysis. These elements ensure patient safety by adhering to ethical guidelines and maintaining rigorous scientific standards for data validity and regulatory approval. Dr. Alvarez, a principal investigator, is overseeing a clinical trial for a new antihypertensive drug. A participant developed severe angioedema 2 weeks into the trial. Dr. Alvarez notes that this reaction is not listed as an anticipated adverse event in the protocol. What are Dr. Alvarez's obligations regarding reporting, and how should the incident be handled? Answer: Dr. Alvarez must follow these steps: immediate reporting, notify the Institutional Review Board and the FDA within 7 calendar days for a life-threatening unexpected adverse event per 21 CFR 312.32 documentation. Use medical dictionary for regulatory activities, codes to standardize reporting, amend protocol, modify the protocol to include angioedema as a potential risk in subsequent iterations, inform participants, update the informed consent documents to reflect the new risk investigation, conduct a root cause analysis to determine whether the drug caused the reaction. This ensures compliance with FDA regulations and protects participant welfare. How can population health analysts leverage data on income and education levels to design interventions that reduce health disparities? Answer: by analyzing data on income and education, analysts can identify vulnerable populations. Income below poverty level and low educational attainment are linked to poorer health outcomes. Targeted interventions. Programs like subsidized clinics in low-income areas or health literacy workshops can address these disparities. Policy advocacy. Data can support proposals for Medicaid expansion or increased funding for community health programs. Outcome measurement. Evaluate the intervention's success using metrics like reduced ER visits and improved preventive care uptake. Evidence-based interventions ensure equitable resource allocation, improving health outcomes in underserved populations. What methods can be used for cohort segmentation in a population health management program, and why is risk stratification critical? Answer: methods for cohort segmentation. Clinical data. Use chronic disease prevalence, such as diabetes or COPD, demographic data, age, gender, and socioeconomic status, utilization patterns, emergency department visits and hospitalizations, predictive modeling, machine learning to predict future high-cost patients, importance of risk stratification, efficient resource use, focus interventions on high-risk patients to prevent costly complications, improved outcomes, tailored care plans, enhanced disease management, regulatory compliance, aligns with CMS quality initiatives like the Hospital Readmission Reduction Program. Describe the data analytics methods used to track the outcomes of diabetes management programs and the metrics for evaluation. Answer: data analytics methods used in chronic disease management programs like diabetes often involve the integration and analysis of clinical, claims, and patient-reported data. Key methods include trend analysis. Monitoring hemoglobin HbA1c levels over time allows providers to assess long-term glucose control. Statistical techniques such as moving averages or regression analysis can be used to observe trends in these markers for patient cohorts. Predictive modeling. Using predictive models such as logistic regression or machine learning to forecast complications or hospitalizations due to poorly managed diabetes. This can help identify patients at risk of severe outcomes, allowing for early intervention. Patient segmentation. Using cluster analysis or decision trees, patients can be grouped based on their risk levels or adherence to treatment plans. Data visualization. Interactive dashboards displaying metrics like HbA1c levels, blood pressure, medication adherence, and hospitalization rates provide actionable insights. This allows healthcare providers to track program effectiveness and adjust care plans accordingly. Metrics for evaluation. Clinical outcomes. Reduction in HbA1c levels, blood pressure control, and reduction in diabetes-related complications, e.g. amputations, retinopathy, utilization data, reduced hospitalizations or emergency visits related to diabetes complications, patient adherence, medication adherence rates, frequency of follow-up visits, and participation in diabetes education programs. Cost savings. Analysis of cost savings through reduced complications or hospitalizations, potentially improving the ROI of diabetes management programs. These data analytics methods and metrics allow for a comprehensive assessment of diabetes management program effectiveness, ultimately aiming to improve patient outcomes and reduce healthcare costs. How does health information exchange enhance clinical decision-making, and what are the primary challenges in its implementation? Answer: health information exchange significantly enhances clinical decision-making by providing clinicians with access to a comprehensive and up-to-date patient history, regardless of where the patient has previously received care. This information exchange enables better informed decisions, reduces the likelihood of duplicate tests, and minimizes errors such as drug interactions or contraindications due to incomplete information. HIE improves the coordination of care, especially for patients with chronic conditions, by providing a clear view of their health status and treatments across multiple providers. However, several challenges exist in the implementation of HIE systems. First, interoperability between different electronic health record systems remains a major barrier. Standardizing data formats and ensuring seamless communication between systems are critical obstacles. Secondly, there are concerns about data security and patient privacy. Protecting sensitive health information while facilitating sharing between entities requires strong encryption protocols and adherence to privacy laws such as HIPAA in the US. Finally, there is the challenge of financial investment in HIE infrastructure, as many healthcare organizations may lack the resources for implementation and maintenance despite the long-term cost-saving potential. How can social determinants of health, ESTO, be integrated into population health analytics, and what impact does this integration have on healthcare outcomes? Answer: social determinants of health, ESTO, refer to the conditions in which people are born, grow live, work, and age, which affect their health outcomes. Integrating SDOH into population health analytics involves collecting and analyzing data on factors such as income, education, housing, access to healthcare, employment, and the environment. Incorporating SDOH into analytics allows for more personalized care plans. For example, patients in low-income areas may face transportation barriers to attending medical appointments, so care teams might prioritize telemedicine or offer transportation services. By analyzing SDOH data alongside clinical data, healthcare systems can target interventions more effectively, such as providing education on health and nutrition to underserved communities or offering community-based support services. This integration significantly impacts healthcare outcomes by improving health equity and reducing disparities in care. Addressing SDOH can lead to better population health outcomes, such as reduced hospital readmissions and improved management of chronic diseases, while also reducing overall healthcare costs by preventing complications that stem from unmet social needs. How does the Case Mix Index, CMI, influence resource allocation and reimbursement in healthcare, and what role does it play in clinical data management? Answer: the Case Mix Index, CMI, is a critical measure used in healthcare to reflect the diversity and complexity of patients treated in a facility. It is derived from the diagnosis-related group used in inpatient care. CMI plays a key role in resource allocation and reimbursement as it indicates the severity of patient cases, which helps determine how much reimbursement a healthcare provider will receive for treating those patients. A higher CMI suggests that a hospital is treating more complex cases, often leading to higher reimbursement rates from insurers, including Medicare and Medicaid. By accurately tracking CMI, hospitals can allocate resources more effectively, ensuring that staff, equipment, and services are aligned with the level of care required for different patient populations. In clinical data management, this requires meticulous data entry, accurate coding of diagnoses, and compliance with coding standards like ICD-10 to ensure that the CMI is correctly calculated. Moreover, the CMI can be used to monitor trends in patient acuity, allowing for adjustments in care strategies or staffing levels based on the complexity of the patient population. How should healthcare organizations track and report adverse events using MEDRA codes, and why is this process important for patient safety and regulatory compliance? Answer: MEDRA, Medical Dictionary for Regulatory Activities, is a standardized medical terminology used by healthcare organizations to classify and report adverse events AES consistently. It includes codes for various medical conditions, side effects, and treatment outcomes, which allow for the systematic tracking of patient safety data. By using MEDRA codes, healthcare organizations can ensure that adverse events are reported in a uniform way, aiding in the detection of trends and helping regulators evaluate the safety of drugs or treatments. The process of using MEDRA codes for adverse event reporting involves the accurate identification of any unexpected or harmful outcomes associated with treatments, medications, or medical procedures. Once the event is identified, it is coded according to the MEDRA system and the report is submitted to regulatory bodies like the FDA or EMA. This process not only supports patient safety by allowing quick identification of potential risks, but it also ensures compliance with regulatory requirements. For instance, pharmaceutical companies are legally obligated to report adverse events using MEDRA codes during clinical trials or post-market surveillance to maintain their market authorization. In the context of diabetes management, how can predictive analytics improve patient outcomes, and what role does data play in identifying at-risk populations? Answer: predictive analytics can significantly improve patient outcomes in chronic disease management by identifying at-risk patients early and enabling timely interventions. In the case of diabetes management, predictive models such as logistic regression or machine learning algorithms can analyze a combination of clinical, demographic, and behavioral data to predict which patients are most likely to experience complications such as diabetic retinopathy or cardiovascular issues. For example, by examining data such as past AC levels, blood pressure readings, medication adherence, and lifestyle factors, e.g., diet, physical activity, predictive analytics can identify patients who may need more frequent monitoring or adjustments to their treatment plans. Early identification of at-risk patients allows healthcare providers to intervene proactively, potentially preventing serious complications and reducing hospitalization rates. Additionally, data plays a vital role in identifying populations with a high risk of developing diabetes or complications due to factors such as socioeconomic status, race, or access to care. How does risk stratification help healthcare providers in managing patient cohorts, and what are the primary challenges in implementing it? Answer: Risk stratification involves categorizing patients into different risk groups based on their likelihood of developing specific health conditions or requiring high-cost interventions. By using a variety of factors such as clinical history, demographics, comorbidities, and behavioral health data, healthcare providers can prioritize patients who are at higher risk of adverse outcomes. For example, patients with multiple chronic conditions like hypertension, diabetes, and obesity are often classified as high risk and may require more intensive care or frequent monitoring. Implementing risk stratification allows for more targeted interventions, such as offering personalized care plans, scheduling more frequent checkups, or coordinating care with specialists. It helps healthcare systems allocate resources more effectively by focusing efforts on the patients who need it most. For instance, high-risk patients can benefit from disease management programs designed to prevent hospital readmissions or manage complications before they become severe. The primary challenges in implementing risk stratification include ensuring the availability of accurate and comprehensive data, integrating multiple data sources, and maintaining privacy standards. How is data quality measured in healthcare? What are the critical dimensions of data quality that data analysts should monitor, and how can they address data quality issues in real-time clinical settings? Answer: critical dimensions of data quality. Accuracy. Data should be free from errors and accurately reflect the real-world scenario. Completeness. All required data should be present and not missing. Consistency. Data should be consistent across systems and over time. Timeliness. Data should be up to date and available when needed for decision-making, addressing quality issues. Data analysts can use automated tools to identify anomalies, perform data cleaning procedures, and apply data validation techniques to ensure that data remains accurate and useful for clinical decision-making.